Good morning, afternoon, or evening to you, wherever you may be. My name is Brennan Mandel. I'm the Director of the Innovations Program at Jhpiego, and I would like to welcome each of you to the second of the webinar series, Ideation to Impact. This session, called LEAP, will address some of the very practical considerations related to research and commercialization for maternal and newborn health technology. We know many of you represent a vast array of disciplines and experience, and you have joined today because of your interest in and commitment to maternal and newborn and global health. For that, we thank you. Jhpiego has chosen to convene this webinar to capture some of the momentum and diversity of expertise, as well as to surface some of the exciting work that is happening. We believe that the meeting of unlike minds and greater collaboration really is the key to success. I would like to thank Jhpiego Innovations for helping develop and organize this webinar series. If you missed our kickoff webinar 2 days ago, the video recording is available on jhpiego.org. We had a terrific panel and discussion addressing some of the key elements of design and the importance of viewing technology as part of a solution, not a solution in itself. It is now my honor to introduce Ms. Wendy Taylor as the moderator for this webinar. Ms. Taylor is the Director of Center for Accelerating Innovation and Impact at USAID, which promotes and reinforces innovative, business-minded approaches and solutions to accelerate impact against some of the most pressing health challenges, including in maternal and newborn health. Ms. Taylor?
Great. Thanks, Brennan, and good morning to everybody, or afternoon or evening, depending on where you're calling in from. But we're really pleased to be with all of you, even virtually. This is an exciting format, and this is a topic that is very near and dear to my heart, one that we spend a lot of time thinking about day in and day out. So I really expect quite an excellent and robust discussion, but also in great part to the fact that we have an esteemed panel who are going to bring a lot of really important insights into the discussion, and so I think we will all learn a lot at the end of this session. So as Brennan talked about, we've got the focus of this webinar series on what's required to accelerate scale of emerging innovations and better inform their design. And today we're actually narrowing in on what is the evidence that's necessary to move a product from early concept to product launch. So if you saw the framing of this conversation, Jhpiego talks a lot about 3 pillars of success for a maternal newborn health innovation. From technical efficacy to public. If somebody's on the line, can you please mute your phone? Technical efficacy to public health impact to market viability. And when we think about these 3, there's a ton packed into each of these, and I think we're going to get into them in the conversation, but I just want to frame a little bit of this now. So when you think about technical efficacy, it's not enough for the product to technically work. These are products that have to work in the context in which they're being delivered. And when we're talking about global health in developing countries, we're talking about areas where they're fraught with very real constraints, from lack of reliable electricity to low-skilled healthcare workers who actually have to be trained to use your innovation and understand its value. If you're working with a device, you have to think about how to clean it and get your parts replaced or fix it if it gets broken, and what are the customs and the practices related to the acceptability of the product. So if you're smart enough to get this all right so your product actually works in some context, you also have to realize that these contexts can change. It can change from country to country, sometimes even community to community. So getting your technical efficacy is a pretty complex issue. When we're talking about public health impact, you've got the challenge of demonstrating your health impact both in your controlled settings where you're running your trials, but also then replicating in trials where you don't necessarily have full control over how it's being used, and can you demonstrate the same impact? And that has implications for how your product is perceived both by practitioners as well as users. And you also need to build in, it's not just impact, but also cost effectiveness of your product. And then finally, when we're thinking about market viability, there's so much packed into this as well. And market viability is something that's, I think, often underestimated and not as well understood in global health. And it's a lot more than just understanding who's going to buy your product and how much they're going to pay. you also really need to deeply understand your customers. You need to understand macro trends that are happening in the market, and you need to understand micro trends that are specifically related to your product, such as who are the patients, who are the payers, who are the healthcare providers, who are your competitors. And then you're going to understand how you're going to get your product to the end user, and that's not just about the supply chain and the distribution channels, but what's the political and the legal and the regulatory and social context in which you're operating. So you have to understand all of these different pieces, and you have to build the evidence base around all of these pieces. And these are what you have to understand this to be able to then attract the interest and the investment of your public health and commercial partners and your investors. And all of these things are also essential to scaling your innovation. And we know that you just cannot underestimate the challenge of scaling. So just to talk about that for a second and bring in context of the center where I work, I mean, we know that there are so many innovations littered throughout the developing world that have failed to scale, and so many other great high-impact innovations that have been introduced, but they're often introduced in the developing world late. Their adoption is too slow, or adoption gets stalled before reaching its target impact. And when we look at industry, industry is laser focused on scale. They bring their market teams together with their R&D teams very early on. They plan for introduction several years before a product actually introduced. They apply these well-honed processes and rigor to launch and scale a product so it reaches that peak market in some short period of time. So at the Center for Accelerating Innovation and Impact, which I lead, we're focusing closely on what it takes to accelerate the development and scale of global health innovations. And we're bringing this business and marketplace thinking, this kind of same business rigor and discipline to how we not only accelerate the development of products, but think about planning for their introduction and successful scale in developing world. So just one kind of large piece to kind of put on the table to think about as we go into our discussion today. And it's a key message that we talk a lot about in the center, and that is that planning for all of these pieces and planning for scale must happen early and often across the development life cycle. So one of the best places to fix problems with scale is in the lab in the first place. That means you need to design with the end in mind. We hear that phrase a lot. Well, what's it really mean? Well, you need to design your target product profile with a clear understanding of the end user. Who is that target user? What do they need? What do they want? What will they pay? How will they use it? How are you going to get it there? So you need all of that evidence base. We're going to talk a lot about evidence. You need all of that evidence just to build that into your target product profile in the beginning. But there's so much more evidence that needs to be gathered and built into the strategy for scale well before launch. For example, when you're planning for product introduction, which countries and when, which market segments and distribution channels and messages will drive the biggest impact? How are you going to generate demand? Who's going to make it? Is there sufficient margin for your product? What does it cost to distribute? So to help clarify all of these steps, and I threw out a lot right there, and we're going to talk a lot about that today, but one of the things I'm just going to mention is that we in the center, we're actually developing a user's guide, which we're going to launch later this year, which includes a delivery framework that outlines all of these key activities and the kind of evidence you need to be generating and work you need to be doing at each stage. We're complementing this with a number of case studies, which PATH has been developing for us, which bring in a lot of the lessons learned about what goes wrong when you miss key steps. And then we're going to couple that with an integrated delivery plan, which really goes into a great deal of outlining all of these activities, and we're going to provide some tools for collecting and organizing that information. So I'm going to stop here. I just wanted to give you some food for thought and to frame some of the key issues for today. But before we get into the meat of our discussion, I want to introduce our quite esteemed panel. So first, I have the pleasure of introducing Dr. Joy Lawn. And Joy, she's not only a pediatrician and perinatal epidemiologist with 25 years of experience in global maternal, newborn, and child health, but she's really one of the world's leading experts. She's a force of nature, and we're very, very lucky to have her in our discussion today. She's also a woman with many hats, hard to keep up with. For 10 years, she served as director of the Global Evidence and Policy for Saving Newborn Lives program with Save the Children. And in this role, she focused on evaluating and scaling up newborn care with a focus on Africa. That in 2013, she began working with the London School of Hygiene and Tropical Medicine as the first chair of maternal, reproductive, and child health epidemiology. She's also director of the March Center, which includes over 150 leading researchers. She's currently a professor of reproductive and child health. And then adding to these many hats, she works part-time at UKAID, DFID, as a senior research fellow for newborn health. So welcome, Joy. We also have Steve Brook, who is an advisor for commercialization and corporate partnerships in PATH's Technology Solutions Global Program. And in this role, he provides strategic input across numerous project teams. He leads multiple teams centered on innovative pharmaceutical delivery and packaging systems, and serves as a senior problem-solving resource for the commercialization staff in the Technology Solutions Global Program. He has expertise in multiple areas, from pre-fillable injection devices to drug development programs to demand and supply analysis of complex markets, and has tremendous insights to bring to our discussion today. And then finally, I mentioned Tora Laerdal. Tora is chairman of Laerdal Medical, but he also established the nonprofit Laerdal Global Health in 2010 with the mission of helping to reduce maternal and infant mortality in low-resource settings. He's chairman of multiple boards, including the Cancer Research Foundation and SAFER, which is a foundation for medical education and research. He's also executive director of the Laerdal Foundation for Acute Medicine. He's an honorary member of the American Academy of Pediatrics. And I also just have to mention he's an incredible partner to USAID. He's not only playing a critical role in our successful Helping Babies Breathe partnership, which I'm sure he'll talk more about, but he's also leading the way for companies to think creatively about how to develop innovations that are designed for developing world markets. And he's been a real inspiration to the field. So I'm really pleased to welcome Tora as well. So with that, I hope you're working on lining up your questions as you hear our speakers talk. So I am now going to turn this over to Joy Lawn, who is going to be our first speaker. And Joy is going to talk about how innovations are evaluated to determine their public health impact and how you can most effectively communicate that evidence to all of the various users who need that. So Joy, over to you.
Thank you so much, Wendy, and good morning, afternoon, evening to everybody from a very sunny afternoon in London. It's my privilege to join you, and in the short amount of time that I have, I want to throw out some important themes and I think also raise some questions about how we collect and use data at each step in the process from ideation to impact. But before doing that, I really want to commend Jhpiego for organizing this event. And I think Wendy's line about the on-like minds is the critical part for successful innovation. And Wendy, in her leadership role at USAID, has really played a very important part in bringing together on-like minds, and I think accelerating the pace of innovation for maternal and newborn technology, particularly in the Saving Lives at Birth program. So if we could move to the next slide, please. I want to throw out three questions. First of all, when we start out, when we're thinking about an innovation, how can we intentionally use metrics to select an innovation that's likely to have higher impact? What are the things we need to ask ourselves? And that doesn't always mean picking the biggest cause, picking the biggest condition. But we need to be very intentional, because to put a massive amount of effort into something that's addressing a small cause, and one small part of that is obviously starting out with less chance of impact even before we face the challenges of scaling that. Secondly, how do we define the impact? And I'm very happy that you've added this talk to this session on innovation. So many of the sessions that I've been to on innovations, we're fantastic at pulling in market forces and advice on that, pulling in industry, and I think both of those are very important. But in many cases where we fail, I think, is we don't collect the right data or plan the right data to collect. And that can also be about the market and client acceptability side, but also on the correct case for public health impact. For example, few studies intentionally collect the running cost, which is often what people will ask. And then thirdly, how do we describe that impact? So you can believe from the beginning that you've got a game changer, but you are unlikely to be able to make that case without collecting the right data and taking that forward. So the next slide, if we look at this first question, I want to break it down to a few parts. First of all, what will we focus on? What outcomes, whether it's mother, baby, don't forget the stillbirth, the causes, what conditions to focus on, when to focus on, and where, and particularly taking into account very different contexts when we're designing for impact and thinking about the potential there. Next slide. So when we look at what outcomes, here we are on this seminar series looking at the promise for maternal and newborn health and outcomes. And after the last 20 years of the MDGs, we've seen more focus than ever on maternal and child health. And yet at the end of this time period, we still have almost 300,000 women dying while giving life. Unacceptable. At the same time, we still have more than 3.7 million children who die after the first month of life, and that isn't the major focus of this seminar series, but I would like to flag to you that in fact the major issue for many of those 3.7 million is stunting. We've made very little progress with reducing stunting, and in fact at least a third of children who are stunted start out either as a small or preterm newborn. So even within the child deaths, a healthy start becomes increasingly important. And then within these outcomes that we would like to focus on, our vision for what should be changed, almost 3 million newborns, 44% of child deaths, and click please, also 2.6 million stillbirths that weren't counted within the MDG framework, but also count for women. And in the recent Lancet Every Newborn series that we launched a couple of weeks ago, we showed that newborn deaths, 71% are preventable with the things that we have in hand. The innovations are about how to deliver those, but obviously we still need further innovations to take that to a higher level than 71%. But for stillbirths, we're really at around 50%, and most of the stillbirths that we can avert are the 1.2 million who die during labour. And this needs urgent attention, not just for doing what we do know to avert those deaths. So no baby, no woman should be going into labour with a live baby and ending labour with that baby dead. So that's something that we do have solutions for, but in the broader scope of stillbirths, particularly stillbirths who are antepartum stillbirths, so dying before labour, we have a major innovation gap. And these two outcomes, the newborn deaths and the stillbirths, the average annual rate of progress is about half the speed of the postneonatal deaths and at least 30 or 40% slower than for maternal deaths. So not only are these a big amount, an increasing proportion of the burden, but they are moving slower and urgently need innovation right along the chain. How do we innovate both in delivery but also have further things coming up the pipeline, particularly for large prevention questions like prevention of preterm birth and dealing with antepartum stillbirths. So at the end of this 20-year time period of the MDGs, at least the last 10 years, a remarkable amount of focus and investment, and I think the last 5 years more innovation. We're still left with 9 million deaths, 2/3 of which are related to birth. So the whole agenda of saving lives at birth and innovation around this time period is completely critical. And within that, 5.5 million babies who die, and the fact that they enter and leave the planet without a birth or death certificate suggests that our society isn't counting them. And counting them is also about recognizing that we have prevention and intervention solutions that need to be taken forward and can be done differently. So we also need innovation around how we increase birth and death certificates and accountability for these deaths. Next slide. So, and this is really emphasizing this same point, that the birthday is your greatest risk of death and of disability. 1 million babies dying on their first their only day of life, 1.2 million stillbirths, and over 100,000 maternal deaths on this critical time period. So if you're looking for a bang for your buck out of innovation, this is the time not only when you get a triple return if you look at the mortality outcomes, but a quadruple return. So in the post-2015 world, we will be moving forward in terms of thinking not just about death, but about development outcomes, and your human capital is strongly determined by what happens at the time of birth. So if we think about the time of focus, this time is critical. If we think about the causes for maternal and for newborn death, anything that we can do that particularly influences innovation and action around this time will get you major and multiple returns on investment. But the investment and how that looks really varies dramatically around the world. So you think that on your birthday all of us started the same. We came into the world naked, very vulnerable. Maybe we cried, maybe we didn't cry, but we don't enter equal. So if you move to the next slide, around 11 million women and babies have their birth in a high-income country. And what happens for the woman if she has a complication, what happens for the baby, is entirely different to should she be born in rural Ethiopia at home. And this has been the major focus for technological developments. I started my professional life in neonatal care in the UK. And every year, even 20 years ago, and even more frequently now, the technology changes. And so the technology drive here is the vast amount of the innovation that is particularly for newborn care and particularly around preterm care, but also for maternal health care. And yet this is around 2% of the world's maternal and newborn deaths, and has been the focus. And it's not appropriate to just take a machine that was designed for this context or even an idea without really rethinking how does that fit, what part of the causal pathway, is it necessary or sufficient, is it designed for purpose, is it actually even something that is an issue to contexts that are very different. But on the other hand, the world has changed in the last 20 years in terms of newborn care. Because if we go to Toronto Sick Kids or to Scandinavian units or units in the UK now, we have reduced the intensity of neonatal care. We've made it more mother-friendly. This is in fact where kangaroo mother care is being scaled up more rapidly than in South Asia. So the whole shift back to more mother-centered care, more family-centered, more developmental care, is also de-intensifying what happens in terms of ventilation, so much more use of CPAP and so on, and also gives us an opportunity for synergy in low-income countries. The next slide, the second world or middle-income countries, is now around 34 million births, but this is the fastest growing. So if we project forward to the end of the post-2015 goals, which are likely to be for 2030, the vast majority of the world's births will be in middle-income countries. And yet, in many middle-income countries, I've spent most of the last decade in South Africa, you have all worlds in one country. This is true also Brazil today. This is the start of the World Cup. Brazil has all four worlds in one country, places where you could have the highest level intensive care through to still having home births with the intermediary of the over-crammed and low-quality facility births. And in many of these countries, this is still driven by whether you're rich or poor, whether you're educated or not, whether you live in a city or a rural area. So as we scale up in these settings, we can do more in terms of ambition with technological innovations, but all the time we need to keep our eye on what we're doing with equity, because technological innovations, especially that require a high degree of complexity, will increase inequity in almost all cases when they're first introduced. And we need to be intentional about how these will reach the poor. And I think there are fantastic examples from innovations in immunization world where they set out with advanced market agreements to intentionally make sure this reaches the poor. But one opportunity that comes out of these colliding worlds within one country is that these can become incubators of innovation. So South Africa, Brazil, China, India, where within a few kilometers of each other you can be having the most desperately poor home birth, or you could be having the highest technology, are opportunities not just to keep those worlds divided, but to find ways to synergize and break down some of our box thinking on innovations within those very countries, possibly the greatest opportunities. If we move to the next slide, and this is what we would maybe call the third world, but in fact is the majority. So 40 million births in facilities, and this is the area that has changed most dramatically in the last 5 years. Just this year, Africa hits a tipping point of 50% of births in facilities. And on the left of the slide here, you can see a hospital I worked in Ghana for 4 years. On the right, you can see a nursery in India where normal babies are still being split from their mothers, and even sort of the ability to breastfeed and provide simple care is still lacking just because of overload in facilities. So this amazing shift into facility birth, a shift in social norms and a change in what women expect and what should be demanded for both those women and those babies is both a challenge and an opportunity. At the moment, in some of these facilities, we're doing more harm than good. We're passing infections, we're creating infections, we're creating deaths that shouldn't be happening, and also disability that we aren't following up. And yet it's also an opportunity, because if we look at this huge number of births that are in facilities, innovations either in care practices or in devices can rapidly reach women and babies who aren't getting the care that they should get and make a big turnaround. And in the Lancet Every Newborn series, we estimated that 2 million deaths of women and babies every year could be saved at about $95 per capita just by addressing the current quality gap within facilities. So this is something that is an innovation and high impact gap. And if we move to the next slide, this is the final and what I would call the invisible world. 50 million births that are still happening at home, at least 40 of them without a skilled attendant. In South Asia, 2/3 of home births may be with a traditional birth attendant, but in Africa, 2/3 of home births, the woman is without any attendant. So this is an imperative for innovation. Some of that innovation particularly needs to focus on how we bring care closer to home, but also bring families into effective care. And if we're designing for this world, we need to be realistic about what this world is like, and also about the lower caseload. So for example, if you're thinking of a community worker who's going to do something at birth, in most cases it's hard to get community health workers to that birth, and the average worker may only do 20 or less births a year compared to a midwife who's doing 200 or less births a year. So your potential for impact, especially immediately at the time of birth, is much lower in community settings, whereas for something like chlorhexidine, which can be delivered by the mother, and although it is time sensitive, it's not time sensitive in terms of minutes and seconds, which is the case at the time of birth. Is something that's more likely to achieve impact in these contexts. So if we move to the next slide, this is just to summarize question 1, and for the other slides I have a lot less to say. But here I think just keep in mind we must focus on major issues. We need to think about things that affect women and babies and lead into impact for children. intentionally focus on the poorest. It's easier to innovate, to reach urban areas, to reach the rich. Remember that just changing one thing in the chain, the technology, may be necessary, but it's almost never sufficient. We need to target other things in the causal pathway, especially workers and especially empowerment of families to change behaviors. And then if you're particularly looking at one area or comparing one area to another or one intervention to another, consider using something like the Live Save tool. So this is free software that you can download from the Futures group. Works on cause-specific mortality for maternal, newborn, stillbirths, and children, and also stunting, that would allow you to estimate. And remember that all models are wrong, but some are useful. So it's not telling you what will happen, but it's giving you a range of what that impact may be. So for example, if you were able to address all cases of maternal syphilis, you may reduce neonatal deaths by about 60 or 70,000 a year worldwide. But you could reduce stillbirths by a further about 150,000. So if you don't count the stillbirths in your impact, you would be missing the biggest effect of innovation around syphilis. So if we move to question 2, and I just have one, just a quick slide here just to say that also in addition to the Live Save tool, there is Mandate, and you can look at this website. And I just asked the Mandate team this week for an update. At the moment, the stuff that's on the website is from, I think, 2009 causes of death. So it isn't the most recent cause of death. It's fed through a software a bit like LIST, adapted from LIST, but allows you to look more at this kind of causal network. You know, if you were to look at introducing surfactant, for example, in a pathway with also antenatal corticosteroids, how much additional impact would you get from that? And then also adding in something like CPAP. So if you're looking at a package, which one would be likely to have the impact in a pathway? And should you be thinking about all of them as a package and not separately? Okay, so moving on to the next question, question 2. And I think, I shouldn't need to labor this to this audience, I'm sure, but please do make sure if you're looking at an innovation, especially something that truly is a new innovation, don't just run to get marketing funding for that and speak to market people and take it forward without looking at the potential impact. You will do yourself more favors in the end if you have a realistic and more rigorous summary of the impact. And secondly, it's possible that if you rush ahead just with something that seems a nice idea and everybody likes, but you haven't evaluated, that at the end of the day you risk doing more harm than good. So for example, if you have something that's a device to keep babies warm, but is not putting the baby directly with the mother, are you reducing breastfeeding? Are you at greater risk of overheating this baby? And have you evaluated those risks as well as possible benefits before you start rolling something out? I think this is critical because if we look back even 5 or 10 years ago in this field of maternal and newborn health, in many ways the technological innovation had a bad name. It wasn't something people wanted to do. And there's a risk that we swing the pendulum too much the other way where we focus only on innovation. I heard Michael Anderson from CIF last week say that innovation is valued, and he values execution, actually doing things, implementing. And I think we need both, but I think we will get innovation a bad name if we take devices that look attractive and we start marketing them without considering really what the benefit is and also what the potential risks are, and being sure that we have the right pathway to scale. And I think that some of the time people within the market side or within the innovation side are put off by researchers. They think you only have to have a rigorous randomized controlled trial that will cost millions and take a decade to do. And there are much more innovative evaluation designs which still remain robust but are much more feasible. And I would encourage you to seriously think about that. And then on question 3, so just one slide on this as well. So how do we describe the impact? Well, of course, all of us want to say that this will save millions. I think you're there at Jhpiego, and I know that Hopkins has that wonderful tagline, saving lives by the millions. It seems to be that in global health, anything that saves tens of thousands, which you would think is fantastic, or even hundreds of thousands, which is remarkable, is not good enough unless it's by the millions. But I think overselling in the end doesn't do favors, may backfire in the longer run. And as we go to sell to a given audience, and others on this seminar, and we'll talk more to this, but clearly who you're talking to, whether it's a research audience, whether it's a policymaker audience, whether it's the donor audience, whoever it is, use the data in a way that really communicates to them. Rate reductions or risk reductions usually mean nothing to the average policymaker, whereas numbers of lives saved, cost per life saved, and personal stories often are what counts. But don't be so clever in your communication that you're also masking real issues in the data. Those are things we have to face. And so on the final slide, I would really underline that data has a role to play at every step of this process, as we define, as we discover, as we develop, and as we deliver. And as we go into large-scale delivery, we often neglect the data, whether that's coal-face data where people are implementing and collecting the data to improve the client intervention actually at that point, or collecting the data further up. But something that we neglect even more than the collection of data, I think, is the capacity that people have to collect and use data. So my appeal to this audience, I don't think I need to appeal to anyone to invest more in gadgets. I think probably that's something that in many ways the pendulum risks having swung too far. I love gadgets and I'm all for them. But I think if we fail to invest in people capacity to assess that evidence, to work out how best to use those, how to scale them, how to reach the poor, how to measure change, and how to do that in their own countries, that we will, over the long term, not achieve the impact that we want for the poorest. So final slide, I just want to flag, I haven't talked much about the great momentum for newborn care at the moment, but we have the launch of the Every Newborn Action Plan in a couple of weeks, and the follow-on from that will be the Every Mother, Every Newborn Quality of Care Initiative. And within that, we're looking for innovation in service delivery, innovation in gadgets, and also in accountability to really be sure that every woman and every newborn will count and will get a chance. And there's a lot more information on this website, the Every Newborn, and also on the Lancet series. And I think we need all of you and all of your brains and all of your on-like minds to really make this become a reality around the world. Thank you.
Excellent. Thank you so much, Joy. That was enormously valuable and a lot of information in there, but I think I'm sure also I can see is generating a number of questions. So let me quickly turn to Steve. Steve is going to talk about some of the evidence building we need to do in that middle of the value chain, both in terms of demonstrating technical performance and market viability. And Steve, if you could keep it to 10 minutes, I want to make sure we have time for a robust discussion. So hand it over to you, Steve.
Thanks. Appreciate the opportunity to speak with everyone today. And I want to thank Brennan and Wendy for putting an excellent program together. Next slide, please. So I think one of the key themes that we will all be talking about, even if we don't say it out loud, is this is all about partnerships. You know, it's an approach PATH has taken over many, many years, recognizing that we can't have impact if we're not engaging with both private industry and the private sector, and the governments, and other civil society organizations. And we've really come over the last couple of years to think more about how we focus the communications and framing around the work we do in product development, which is a big part of our portfolio, although we also work a lot on service and system innovations too. So we've developed sort of our version of a value chain, similar to what Joy just outlined, from starting with research and design and moving through critical steps all the way to scale up. Next slide, please. And one of the most critical challenges in all of what we're doing is what I like to call, and what other folks call, crossing the chasm. And there's actually an excellent book by an author named Jeffrey Moore called Crossing the Chasm that it's been around a while, but it speaks to this issue of leaping from the middle of the value chain, from the development, from the approval, from the initial evaluations, making that leap to scale up. And that is really one of the most challenging phases in all of this work. So what I'd like to do is just talk a bit about some of the questions we try to have in mind as we start early on thinking about what it's going to take to cross that chasm, and absolutely a huge part of it is about the evidence that's necessary. This slide just gives you a sense of some of the key milestones that happen and the types of evidence that have to be generated, but I'm going to talk in a little bit more detail about this. Next slide, please. So as we're thinking about product innovation and even service innovation at PATH, we often start with sort of a relatively high-level framework of 5 critical areas of assessment. And they touch on really, problem characterization being really focused on what is the public health need and so forth. Technical feasibility being around whether there really is a product that can match a target product profile that will be compelling in terms of having advantages over existing processes and projects. The economic rationale is about the costs and the cost effectiveness. And it's critical to think, even in just a conceptual model way, about those issues very early on in the process, as Wendy has pointed out. We also look at and try to think about how the innovation we're developing can exist in the quote marketplace, in the absence of PATH or in the absence of subsidies. So we don't make or sell anything at PATH. We're always collaborating with industry partners, and the products we work on in the end have to make sense for someone to be able to produce and sell in a marketplace. And obviously a third and critical area is all around policy, both support by policymakers, ministries of finance, and so forth. So next slide, please. So I just want to talk a bit more about the both the technical feasibility, and I've grouped both economic rationale and market sustainability together, because in a sense they really come together to speak to that market viability. Next slide, please. One of the interesting points that I like to reinforce is that really the questions don't change as we move from research and design all the way through the process. What really changes is the level of detail and the level of evidence generated to support those areas. So I really like to reinforce that the questions of technical feasibility and economic rationale and market sustainability are not looked at once and then put away until it's time to scale up. It's critical as we move through as anyone moves through the process of going from developing into the either regulatory approval and guidelines incorporation. It's really critical to be adding additional evidence both on the technical efficacy, on the economic costs and benefits, and on the area of envisioning how the product or service can exist in a self-sustaining way when we or others have finished the work we've done to shepherd it along. So again, I think the critical point is that the questions around market viability and technical performance need to be revisited throughout the process of development. There's really no other way to really generate the evidence that can help cross that chasm from introducing to scale up and applying. And what I'd like to do now is just give a brief example of a couple projects we've worked on, one of which I think is poised and is making it out there to cross the chasm into fairly wide scale up, and one which actually hasn't made that leap. So we've worked at PATH quite a bit with many of you on initiatives to really hone in on getting chlorhexidine for umbilical cord care into the mainstream. And it's taken quite a while, but I think through the collective efforts of the community, there's been an excellent process of generating the evidence necessary to support the value of the product. There's been a good work around identifying and clarifying how the product can be manufactured, where it's optimum to have local manufacturing in countries where it isn't. And also then there's been a major effort around aligning guidelines, working with WHO for essential medicines list and moving those down through the countries. And the evidence has all come together such that I hope everyone agrees that chlorhexidine for umbilical cord care is, I think, really poised now to, in a sense, become fairly self-replicating and scaling up and being adopted across many countries, and it can make a big impact on the neonatal mortality that Joy spoke of. One of the projects I've worked on for quite a while at PATH, it's been dear to my heart, and in the end, it really hasn't been able to make it into sustainable wide-scale use, is oxytocin and Uniject, which is was envisioned to be an important tool in prevention and treatment of postpartum hemorrhage. We were able to demonstrate the technical feasibility of the product and demonstrate that it was very well used, very appreciated by healthcare workers in a number of pilot introductions in countries. We worked with 2 pharmaceutical producers to try to help them get positioned to be able to make the product. What really became challenging in the end is the value for money part of it. When we started the project, we had pricing in mind that in the end was not feasible from a simple manufacturing and production standpoint. So while we started out with a product aiming for a price of hopefully well under 50 cents, in the end it simply was not possible for pharmaceutical producers to make this product for that price, and ultimately the price they would have to charge for it to be sustainable for them in the market was not something that actually then was cost effective. So to me it speaks to an issue, and a lesson learned is to really do the work up front to understand what price does a product we're developing need to reach in order to maintain that economic, that cost effectiveness. And it's quite tempting when one is in the weeds of developing a product to allow those targets to sort of just creep up over time because of positive feedback and a lot of excitement and people wanting to get the product out there. So with that, I'm pleased to be able to hand it off to our next speaker, who who gets to speak to it from the standpoint of our industry partner side.
Great. Thank you so much, Steve. That's lots of good information there, so it'll be good to get into the discussion. Before we do that, we have a here, and that's Tore Lærdal, and he's going to talk from the perspective of a commercial player here, and hopefully give some insights in terms of how commercial partners come to understand global markets and gain that confidence necessary to move forward in innovation and take it to commercialization. So, Tore, over to you.
Yeah, good morning, everyone, and thank you for inviting me to this interesting webinar. I hope you can hear me all right. I am fighting both with a slight flu and a slightly compromised phone line, but I will do my best. If I could have the first slide. Could you go to the next slide? Yes. I am wearing 3 hats, and I will speak about the topic from our experience. So it may be of value for you to understand where I'm coming from. I'm the second generation owner and director of a family-based company called Lærdal Medical, and you see my father here demonstrating CPR or mouth-to-mouth breathing in 1960 on the very first training device to help spread new life-saving techniques that were developed around that time. He actually started out as a toy manufacturer and made realistic-looking toy dolls in the 40s and 50s. So this company, since the breakthrough of modern life-saving techniques, around 1960, has for 5 decades been the international market leader in that sector. And we today have a well-consolidated family-owned company with around 1,400 employees in 24 countries, and all of those countries are well-developed countries, although they include countries like Brazil and China and India. Lærdal Foundation was set up in 1980 with the University of Oslo to provide financial support to practically oriented research. And in later years, it has taken special interest in saving lives at birth in low-resource settings. And the granting of awards to some 60, 70 different projects in that area in the last 5 years have given us, I think, some good insights into what are the unmet needs. We learned then that with the common mission of these 3 entities of helping save lives, that's really by far the greatest opportunity to do so existed in low resource settings and very much at birth. We actually believe that 80% of the lives we can help save, and more than 95% of the life years relate to saving lives at birth. So for that reason, we, and maybe I should mention, we had in the traditional CPR arena, we had some long-established collaboration with organizations like the American Heart Association and the American Academy of Pediatrics to implement their training programs. That experience made us realize that we needed to think differently to have any hope of having an impact in the global health sector. So we chose to establish a not-for-profit company in 2010 called Lærdal Global Health, which later have entered into 3 public-private partnerships and have now launched around 12, 13 different products And I will speak a little about that experience and how we decide to commercialize product ID. The next slide. We have made or learned 5 lessons in particular from CPR implementation over 5 decades, and we very much believe that these lessons are relevant also in the global health setting. First of all, as both of the previous speakers talked about, innovation, it's important to understand or to define what it is. And we firmly believe that innovation is not about technology, it's not about medical science, it is about incremental impact. And as has been well established, the greatest opportunity for increased impact is better implementation of what is already known. And we believe that this relates very much to efficiency of training, and that training drives therapy, and that local implementation needs to be supported. All of this is then addressed in point 2 here. Implementation is mostly about better education and implementation. Life-saving must be made simple to learn and remember. There is no magic in taking a course if you're not in a clinical setting where you are practicing this under some follow-up regularly. And for instance, life-saving techniques like newborn resuscitation is highly dependent on being implemented in a system where you have supervision and where you have the opportunity to have regular refresher training. And in particular, so if you don't have frequent clinical practice. And back to what Joy mentioned, there is a big difference in training a midwife who may deliver 200 babies a year and a health extension worker having 10 or 20 deliveries, because they have a very different opportunity to practice what they learn. It takes a system to save a life, point 4, and there need to be a coordinated chain of survival locally, and survival is really only meaningful if it can be with quality of life, and therefore it takes a village to raise a child. It takes a system to save a life. And all of this speaks for point 5, that implementation requires collaboration. This is a massive task, and no one, not Lerda, not any other company can really achieve the impact we're after without really working closely together with other partners. And we have been privileged to become a partner in several implementation alliances. And if we go to the next slide, here is an example. Again, you see first an arrow with this value chain that can be depicted as Steve did, or in this way, very similar. Starting with needs assessment, going through concept solutions, iterative prototypes, and then what's supposed to be my focus here, efficiency of manufacturing and commercialization, and then really implementation. The impact will not happen till all of these 5 elements are in place, and the customers are really adopting this product or the solution. Below you see an example of how 3 collaborating partners in the Day of Birth Alliance that we have established jointly with Jhpiego and CIBID, the Center for Bioengineering, Innovation and Design at Johns Hopkins, complement each other's competence. you see to the left that there is a scale for relative areas of excellence. And Jhpiego, which is the red curve, starts with a high relative competence in needs assessment. But their competence is not in iterative prototypes and efficiency of manufacturing, but they are indeed very active again to the right, far right, in implementation. CIBID, the blue line or curve, is really not as close to the needs as Jhpiego, but their expertise is thinking outside the box, coming up with concept solutions, making iterative prototypes, but then it stops again. They don't have any history in manufacturing, and they don't have a manufacturing plant. They don't have the funding for commercialization, and they also have no organization for implementation in the field. So in that way, neither Jhpiego nor CIBID really are armed to do the entire value chain on their own. And this is where Lærdal, as an example, may complement their basis by, as indicated here in green, having relatively more to offer when it comes to experience in commercialization, in manufacturing, and in distribution. And if you add these together, you will see that the potential of three complementary partners is to have a competency that will be on a fairly high level throughout this value chain. And this, I hope you will agree, is a model that may apply for various parties. And if you have a good idea, and many of them are being discussed in a setting like the Saving Lives at Birth, for instance, and I would assume that several organizations or startup companies may be on the line that find themselves relatively to the left of this value chain or business error, and could benefit then from implementation partners like, in this case, Jhpiego in implementation or others, and Lærdal or others in manufacturing. If I take this to our specific experience with some education programs on the next slide, you see training with a Helping Babies Breathe program developed by the American Academy of Pediatrics. This has really reached impact, and therefore I think it deserves to be termed innovative. By now it's introduced in 64 countries. We have very good reason to believe that well over 200,000 have been trained, and we have seen in a study in Tanzania that it has the potential to significantly reduce early mortality. It has also helped to scale up essential life-saving commodities. And in the lower right corner, you see neonatally newborn simulator, a newborn resuscitator, and a bulb suction device. We have developed these for ultra affordability. We have manufactured them in our own plants in China. We have made investments in tooling for large-scale manufacturing, and we have offered them at our direct production cost, which has made it possible to launch them at prices that are significantly lower than if we were operating as a commercial company. And for that reason, we have also seen very much then pulled by the training program that has rolled out, that we have been able to deliver fairly significant numbers or quantities. By now we have around 60,000 newborn simulators and well over 100,000 resuscitators and close to 200,000 suction devices out. This would absolutely not have been anywhere near those numbers if we were, as a manufacturing company, operating on our own, because there has been a pull effect by the training program and by the organizations that are rolling out the training programs. If we go to the next slide, you will see Essential Care for Every Baby, which is a follow-up course which, together with Helping Babies Breathe, form what is normally referred to as essential newborn care. So here we're talking about topics like breastfeeding and temperature support and other things. And we have, again, working closely with the editorial committee of this training program and following the field testing of the program, we have identified unmet needs for training devices, and we have gotten very good feedback from the field testing and have them ready for launch a breast training simulator, and that we feel fits well into this program. That approach has again been very decisive for making this a viable product, and we can produce it in much higher volumes and at much lower costs than if it wasn't part of a collaborative training program that also has the support of a global development alliance or implementation alliance. I know we're running out of time shortly, so let me make only some brief comments to the next slide. This is a third program in the development in the newborn arena, special care for small babies. And that requires a preterm simulator that can also be functional for training in kangaroo mother care and gastric tube feeding. Next slide. Helping Mothers Survive. Mama Natalie. Again, we couldn't hope to sell anywhere near the numbers we're doing if we simply developed a birthing simulator and it wasn't tied in with a training program. This can be summarized in the following slide, where you see what we refer to as Train to Saving Lives, or in this heading, program success criteria that we feel are absolutely essential for making these products viable and making it possible to commercialize them at low cost and high volumes. They address main needs. They leverage the success of the HPV program, which is a locomotive for the other programs. They are highly focused, evidence-based, use highly affordable training tools, and they are peer-led and locally owned. So all of these factors together speaks for it takes a system to save a life. It takes a system also to make a product viable, we believe. So back to an earlier slide, and just to summarize, our lessons learned are, again, that innovation is all about impact. Implementation is mostly about better education and implementation. Life-saving must be made very simple to learn and remember. It takes a system to save a life, and implementation requires collaboration. Thank you.
Excellent. Well, thank you so much to all of you. We've got a lot of rich food for thought and discussion, and this is fun for me. I've been getting the long list of questions. We have lots and lots of questions that are coming in, and more than we're going to be able to handle. So I'm going to put out some questions for our speakers. I'm going to ask all of you to keep your responses short so we can try to cover a lot of ground here. And just to give everybody a little bit of advanced warning is that our organizers have given us permission to go a little bit long, so we're going to, I think we'll be able to take this past 12 o'clock. So those of you listening in, we will try to get as many questions in as we can, and so we're going to try to take this maybe even out to 12:15. So let me start with a couple of questions that we've gotten in around data. One is around market viability, and so when we talk a lot about market viability, but we're talking about working in some very tricky markets where it's very hard to actually get this data. So this market data is not always readily accessible, very hard to gather it. So they're looking for some recommendations from the panel about good sources or methodologies to be able to make the business case. I also want to bring in the idea around actually understanding and translating from need down to demand. And so we got another question about how do we translate health impact into a business case when kind of recognizing that public health need is not necessarily the same as demand. And so how do you take the haircuts off of that to really get good estimates of demand, and particularly in light of the fact that we often don't have good data available. So I'm not sure who wants to field that. Maybe Steve wants to take a crack and others join in.
Sure. I really appreciated Joy's comment about all models are, all models are wrong, but some of them are useful. I think the same is true for demand forecasting. I mean, forecasting is just that, guessing about the future. So that's one of the more challenging areas. In terms of converting need into demand, I think the most critical aspect there, or one of the critical aspects, is again thinking about the whole system of organizations and institutions that are involved not only in using an innovative product, but in recommending it, in determining where it would fit within a budget allocation, and so forth. And so sort of from a funnel standpoint, need is the widest part of the funnel, and then each incremental cut can be based on, well, there's the need, but then a first cut may be, but how many countries actually are ready to implement, and that reduces the need down somewhat. And then how much, how many countries are willing to start purchasing next year. So moving from need to demand is really a process of looking at the pragmatic questions on what it would take to actually get a product into use, and the demand will always be less than the need in terms of the immediate quantity that may be able to be commercially sold.
And what do we do when we have trouble actually accessing this data? I mean, thinking about good sources of data to be able to make the business case.
Yeah, that's one of our biggest challenges. I mean, we work in such a huge swath of scenarios and markets and niches that many of which just don't have the type of data collection that comes in the developed world. So there's not an easy answer for that.
And maybe one thing I'll add is that I think a lot of this also just requires rolling up the sleeves and getting into the markets and doing some of that market research. And the tricky part is actually you almost have to invest in it from country to country. And so what we're seeing is certainly there are. I think we're getting better at and getting better market data. I think companies are getting better at trying to understand these markets, but it's certainly going to take some take some time. So I think there's also you can find local companies that know these markets well, and they are also good sources of groups to go in and do some analysis. So there are ways to get at this information, but it's definitely trickier.
And I think you've hit an important point that it's all local. You know, there really is no such thing as the global demand. There's an aggregated set of local demands.
Great. So let me move on to, I'm going to bring in both Tori and Joy into this, and we have two similar questions. One to Tori is what are your top criteria, if you were going to pick your top 3 criteria for deciding to produce and distribute a new technology-based solution? What are the things that drive your decision-making as to whether or not to take something on? And then, Joy, perhaps you can field this one. Came in saying, recognizing users and customers of technology are not always the same, and can you think of what are the top priorities, whether it's for health systems or donors, when they decide to adopt and purchase and scale up a new technology?
Yeah, I'd be glad to comment on that. First of all, we ask the question, does it really have a likely impact of saving more lives? And if it's not significant in that sense, we would say it's not qualified for further consideration. Then we would look at how does it fit into a portfolio, and does it support a program we have going, and does it support partners that we are trying to help do a better job. If it's an isolated product that would not fit in with other products or solutions and not be part of a program, that there would be much higher implementation costs, and we would not work efficiently. We would also have far higher selling costs, and it would drive, even if we often see unrealistic projections on cost, and I think in a Western market it is not untypical that you can, for a medical device, you can quadruple the direct production costs and to get to a selling price, and to cover R&D costs, to cover distribution, to cover regulatory costs, and to have an acceptable profit margin at the end. Now, in the global health setting, there are a number of additional barriers that would drive costs further up. So we think you can easily underestimate that cost picture and be way too optimistic on what price you could sell or make a product viable for. So we are looking for a different business system than to try to, unless we think we can sell something in thousands and tens of thousands, and ultimately in many cases in hundreds of thousands, we think it would not be a very priority candidate for our product program. One more thing is that therapeutic products and also diagnostic products are far more complicated and much more time-consuming to take to market due to regulatory affairs. So everything others being equal, we would favor trading products that are simpler from a regulatory standpoint.
Great, thank you. And Joy, can you put on you're used to wearing many hats. Put on the hat of a donor and or a Ministry of Health, and talk a little bit about if you were a country, when you're deciding to purchase or scale a new technology or innovation, what are the big driving factors for donors or for ministries?
Yeah, thanks. And if I understood I didn't see the exact question, but if I understood the question, it was about the tension between a client or the end user versus the decision not being made by them, but maybe made by a health system. And I would flag that, in fact, in many cases, those decisions are in fact made not by the person in the health system who's the caregiver, but a manager who may not be at the coalface. So I think there's also the healthcare professional, and then there's also the donor. So I think in each of these decisions, the person who is receiving the intervention may be several layers away from what is a fairly complex and not always transparent decision-making process on how one commodity or one device is purchased versus a completely different purpose of device, or how two potentially equivalent devices are chosen. And I think, WHO Essential Medicines Department started out a couple of years ago to try and develop a tool to try and help governments to decide on this. And in fact, I think it's a critical point, because if you look at the value of the evidence base at the essential medicines list, the WHO essential medicines list, so Steve mentioned that chlorhexidine was added to that last year. Antenatal corticosteroids for preterm labour was added to that last year, despite being the front symbol of the Cochrane analysis for 20 years. So I think for medicines, we have an essential medicines list, and in most high burden, low income countries, it is not straightforward to get a medicine routinely stocked that isn't on that list. We've really failed to do anything like that for essential medicines, essential technologies, and I think that's been a huge gap, and some of that actually is industry lobbying to not want to do that. So I think it is critical that in our moving forward that we look at the capacity of policymakers and the capacity of healthcare professionals to assess what is an important device to invest in, and to think very carefully about how that will be maintained, and to be able to compare different devices using an evidence base. Because I think there's a lot of vulnerability for weak use of evidence or lobbying. And I would reiterate the 3 points that I think Tor made, which I think should be the same also for health system decision making. Does this have impact or potential for major impact? Does it match the portfolio for that level of the health system and the capacity? And will it be feasible to use and to sustain? So I think those are really critical, and that we haven't paid enough attention to that. It's not just the market shaping, but how do we increase the capacity so that these things actually make it into a routine logistics system and are maintained afterwards.
I think that's great. And let me ask a follow-up question. And you talked about some of the tools that we have out there. We have LIST. We have this new exciting mandate tool that many people are excited to be able to put into use, that might allow us to compare across innovations. You mentioned cost effectiveness as another piece earlier as well. Your third point about feasibility to use and sustain, I wonder, have you thought through, are there tools that you've seen, or are there ways to even think about developing a tool around deliverability or scalability, so that as we as donors, or even at the various levels of the health system, think about bringing on new innovations, we really can have a way to measure what is scalable or what might be deliverable?
I think that's a whole webinar in itself. I mean, there is a literature, including a paper that's very widely cited from WHO bulletin 4 or 5 years ago about looking at literally that a score of deliverability of interventions. I'm just blanking on the first name of the author. And that at the moment isn't fully incorporated in mandates, but they make, and I think these are decisions that are quite subjective at times, make a decision at what level of the health system. Is this something a woman could give at home? Is this something that could be given in a clinic even without running water or electricity? Is this something that requires a hospital? Is it something that requires a hospital with quite a high degree of complexity? So I think those things are, those are important at which level, and there are scores around that. And I think we really neglect. I think we neglect also the initial rigorous evaluation. Steve made the example that chlorhexidine had several randomized control trials, and we know from the latest estimates in Lancet, every newborn, it may save, potentially up to around 100,000 lives a year, which is significant. But considerably less than what people said at the beginning, which I think was 1 million. So, I think the amount of lives that, that could be saved by something also would push you further on something that was harder to deliver. So, chlorhexidine should be very achievable to deliver, has a moderate amount of lives saved and is low cost. So you're going to push that faster than something that is extremely complex, unless that had a massive number of lives saved.
Yeah. No, thanks. All right, well, let's switch gears to collaboration. And maybe just on that last point, maybe we need a webinar just on deliverability. I think that's a great suggestion. But switching gears to collaboration, a question came in saying we've heard about the importance of collaboration. We know that crossing the chasm is challenging. Where do you see the biggest gaps in collaboration, and where's the greatest need for better coordination? So, any or all of you?
Great question.
Who wants to jump in? Tora, you want to try that one first?
Yeah, we have really entered this from, as I said, a history of collaboration with the American Academy of Pediatrics. They really want to contribute to having an impact. They have long history in many countries, and in particular with resuscitation. But so I think it's more being invited into a collaboration and addressing or sitting down and discussing and understanding the needs of the collaboration partners. So we are coming from really listening to people who are much closer to the end user and have much more experience with that in the global health setting than we have. And I think that's giving us a far better basis to be a valuable partner than if we started by conceptualizing a product and looking for partners afterwards. So it starts with collaborative partners and joint assessments of unmet needs and iterative prototypes. I think product development in our setting is really made 80% in dialogue with partners and end users. So if we thought up any bright ideas inside our R&D department and then look for partners, I think that is not the recipe that has worked for us. It's the other way around.
Thanks. Steve, you want to tackle that? And you talked a lot about the crossing the chasm. Where are the big areas where collaboration is most critical?
Well, I think one of the most difficult collaborations and the most necessary to do, and again, difficult to pull off, is is at the country level, not only collaborating with, program champions who like the idea and can see how an innovative product or service could have impact. It's really critical to somehow figure out how to engage the other parts of that country system who, as we've talked about, are going to actually make the financial decisions around supporting purchase and introduction of a new product, who are going to make the decisions around expanding a program so that there is a system within which to have uptake for a new product. So I think from the pragmatic standpoint, that's probably the area where we should work the most to try to be more comprehensive on that country level.
Great. So now I'm going to throw out a sort of interesting one. I'm not quite sure where this is going to go, but the question is, as we try to generate evidence to support a specific solution, how do we incentivize good data quality? So if data quality is questionable, that limits actual impact a specific technology can have. So can you use incentives that are, whether they're financial or behavioral or otherwise? So incentives for data quality. Anyone want to try to tackle that one? Joy?
Thanks, Wendy. I think there are two ways to incentivize data. One is the kind of pay-for-performance use of data, and this has been tried. So they're at the classic example, maybe within the HIV world, where wanting to go from not having coverage data to making sure there was coverage data of antiretroviral therapy in a very short amount of time to guide action. And so, paying people selectively to fill the data on HIV. And some of the experience shows, first of all, that may mean you fill other data less and possibly that you falsify that data. So I think that's an interesting experience, but also clearly comes with risks. So I think that the critical thing, we will fail in Tor's line that innovation is actually about the impact. We will fail if we're innovating but not measuring coverage, not sure if our coverage is reaching the poor, not thinking about quality. So I think it's an accountability issue for donors and for governments, not just in innovation but in running systems, that systems depend on data. And I think the investment should be in the system and in people capacity to question data and improve data and use data. And I'm excited to say that as a follow-on for the Every Newborn Action Plan, there's really a movement to try and do that, not just improve the data, but to look at the capacity in countries to improve and use that data. I think it's absolutely fundamental for change in this area of care at birth.
Great. And then maybe just one more question while I have you talking about, since I think this probably would be fielded to you. There was a question that came in wanting to know if you could provide any more examples of novel evaluation designs which have been more effective in low-resource settings rather than traditional methods of evaluation. I know you mentioned some in your presentation.
Yeah, that's a 2-week course at the London School. So complex evaluation, but with designs that are more feasible, particularly where you can't do individual randomization or even where cluster randomization doesn't make sense or possibly would be unethical. So that the ones that people talk about are step wedge design, where maybe you are going to implement in 30 hospitals and you start 2 per month, but you collect data in all of those and you use the rest to compare as a comparison group. There are other things such as propensity scoring, where you may implement everywhere but look at certain variables that you can then try and control for in your analysis afterwards. But I think the bigger picture point, rather than to get stuck in the detail, is it's concerning to me. I'm absolutely for innovation, but it's concerning to me that sometimes if we have something that looks like a sexy gadget that people are excited about, we haven't even tested it on more than 5 people. We don't have safety data. We don't know if it's effective. and people are already marketing it. I actually think that in the end will be counterproductive for effective innovation. So I think, if we're doing something that really is innovative and hasn't been tested, we need to know that it actually has impact and that it's safe. And go and come and speak to somebody who would help you to get a design that's going to work. Don't just start implementing with it.
Great. Well, I think we can move. We could probably talk about these things all day, but I want to leave time just for everyone to have a kind of quick final words, final takeaway message, words of wisdom that you want to impart on our active audience that I feel has been quite engaged, but we can't actually see you all. But any last thoughts? Maybe I'll go to Tor first.
Yeah, at the risk of being repetitive here, it's so fundamental in all we do that, and think that my main point, I think, is innovation is about impact, and it's complicated to get impact, and it requires collaborative or collaboration with partners that can complement your own basis. Even we, with a 50 year of industry history and a well-consolidated company, we cannot achieve much on our own. So work with partners and consider that innovation has not happened until you have really end-user impact and helping save lives.
Great. Steve?
Well, I think I just want to echo the point that's been made about how in most cases we have to have the programs in place first in order to create an environment for successful scale-up and introduction and uptake of innovations within those programs, whether they're product-based or service-based. There are occasional situations where an innovative product can actually help catalyze a change in a program, but more often than not, the critical point is to understand where you can fit in with an existing program and or be part of a bigger picture effort to help strengthen that.
Great. And Joy, last thoughts?
Mm-hmm. Well, I mean, to say, I think as we have already emphasized, that the greatest power for impact will come through integrated innovation. So the gadgets plus behavior change in the health system, plus demand generation, and also through integration of on-like minds, so the markets, the service providers and the researchers, with the heart of that being the people who we're keeping our eyes fixed on, the woman and the baby, and not on the gadget itself. So I'm absolutely for innovation and absolutely for gadgets, but I think if our eyes become essentially focused on the gadget and not on the people that we're trying to reach, we may lose the plot.
I fully agree. And just to give my own kind of final thought is I think when we think about the scaling, I think the strategy for scale is just as important as the innovation itself. And we talk to a lot of innovators who get very excited about the design of their innovation, and those innovators will spend a lot of time building out that idea, sketching it out, doing all the prototyping with whatever you've got around, and continue to build that prototype. And you think about all the iteration that goes into that. Well, they tend to not apply that same kind of thinking when it comes to a strategy, and you often can go straight from your kind of idea for your strategy to what you think is this fully formed strategy. And the strategies for scale, I think, need that same level of design thinking and attention as do you put into your innovations themselves. And you need to be able to even iterate on that thinking as you get better data, get better information. And Steve talked about how important it is to continue to build on that information as you go along. It's not a once and done thing. So continuing to build that information out, really recognizing how important it is to build that strategy out early is very important, and is just as important as the technology itself. So I think we will stop there. This has been an excellent panel, as I anticipated, and thanks also to the audience for your great questions. And so with that, I'm going to end. I'm going to hand it back over to Brennan, who is going to give a few closing words.
Great. Thank you so much, Wendy. I want to thank you to the audience especially for sticking around for an extra few minutes and for your active engagement, and very much to Wendy for a great job moderating, and the panelists for your thoughts and contributions. It was a great discussion, lots of important lessons. We know we didn't get to all of the questions and answers we were interested in, but please follow us on Twitter at Jhpiego, at InnovateJhpiego. Some of the lessons I think that we will continue to take from this webinar is that execution is as important, if not more important, than innovation. And as Wendy just commented, the strategies for scale are as important in design thinking as product design itself. One of the major themes from this, and even from our first webinar, is that it takes a system to save a life, not a gadget. Implementation and the investment in people and programs is central to a solution where technology may be involved, and cases where a product catalyzes a program are much fewer. I think another important piece from both the public health system perspective as well as the commercial perspective is that value for money is one of the most critical metrics for a health system to adopt a technology-based solution, and for potential commercial partners to make that leap into producing and distributing. We identified some challenges in this chasm, as Steve calls it, including gathering the right amount and type of data and the methodologies to do that market research, but made a suggestion that really local companies and local data is a great place to start. So some of the other criteria for making this leap that were identified by the panelists and by Wendy are to consider if A, the technology will make a health impact, B, does it support a program and partners to do their jobs better and work more efficiently, is it compatible with the health system, and is it deliverable? In other words, will it be feasible to use and sustain? So these were some of several key lessons and ongoing challenges and opportunities for the global health community and those working in technology to collaborate and coordinate even more. So thank you very much, everybody. We'll conclude with this. Please join us next Tuesday on June 17th for the third of the webinar series on delivery. Thank you.
Thank you.
Thank you.
Thanks so much. Bye-bye.